for you to get services. Well, now there's a requirement that that can't happen anymore. So that was the Indian Healthcare Improvement Act, which passed as a part of that, and that was a huge accomplishment for us. But let's talk about the Affordable Care Act, which is the healthcare reform law, and what it did, and what we can expect. The first thing that we know is going to happen is it's going to increase the number of people with health insurance. So Medicaid, Medicare, or a state exchange, which I told you we're going to talk about that in a little bit, what that means, or private insurance like Blue Cross Blue Shield, or if you get your insurance through a job or some other source. The second thing is that it's going to make health insurance more affordable, because by 2014, there's going to be expansion of the Medicaid program, and it's going to cover adults that are childless, and you don't have to necessarily have a disability for it. So you can actually, if you meet eligibility requirements, then you can actually get access to Medicaid, and you could have an insurance so that you could get all your health care needs met. The other thing it's going to do is it's going to create these health insurance exchanges, these state exchanges I was telling you about, and they're going to have sliding scales fees, so that you can actually have, depending upon your income, it'll be affordable for you to actually purchase your own insurance at a reduced rate. And then the other thing is we suspect that once more people get insurance, then it's going to reduce health disparities. The health disparities among the American Indian community are greater than any other ethnic group in the country. The problems that we're having with diabetes, with other kinds of behavioral health related things, as you guys are all aware of because you guys are working on those issues, as well as other kind of chronic things, heart disease and stroke and all those things. So the health disparities are big, and a lot of it has to do with the fact that we don't have a lot of money for health care. So this is going to be an opportunity now for people to have a way to pay for their health care, so they don't have to go without or sit on a waiting list forever. And then finally, it's going to bring down the overall cost of healthcare, because the more people that have insurance, some kind of insurance, whether it be Medicaid or a state exchange or private insurance, the more people have insurance, that means that, like, this clinic is going to have money coming in the door, so they don't have to write off bills. Because if a clinic has to write off bills, then they end up charging more for other things, and then the cost of the insurance goes up because the hospitals are having to charge more money, and then the insurance company has to pay that. It's just a vicious cycle. So if we can give everybody insurance, then it's going to bring down the cost of healthcare. And then the other thing that's due is going to expand the workforce. There's a lot of really good workforce programs, like the National Health Service Corps. Now this clinic is eligible for, which means that they can work with the National Health Service Corps to get core people stationed here, like doctors, nurses, and psychologists, and some of those kinds of things. Okay, so let's talk about the Medicaid expansion that's going to happen. In 2010, states were given the authority, because remember this authority law, they were allowed to expand their Medicaid to persons up to 133% of the federal poverty level. So that really expands it. In the state of Michigan right now, it's what, 115 for children? You have to be at 115 or less for children, and if you're an adult, you have to be 35% the federal poverty level or less. But this would expand it so that people with higher incomes are still going to be eligible for Medicaid, so that's good. The second thing is that by 2014, the states are required to make this expansion. So Michigan is now in the process of trying. We met with the state Medicaid folks yesterday, and they're in the process now of trying to figure out how they're going to roll that out. And so that's also going to cover non-elderly, non-disabled, non-pregnant, and childless adults. So that's a really good thing, because before, if you were an adult, it was really hard to get any kind of Medicaid support, even when folks really needed it. And then the other thing that's cool is that the federal government is going to pay 100% of the costs for the expanded population. So that'll hopefully help your state out, because states are struggling financially. A lot of states are struggling. And to ask them to expand it without any additional money would be really difficult. So the federal system is going to pay the states so that they can do that expansion. And so, of course, you know, the impact is the more people are going to qualify for Medicaid, and the more people that have Medicaid, the more money that's coming into this clinic or any of the health services, so that's a really good thing. Okay, The next thing is we're going to talk about these state exchanges, because this is the second part. So if you, let's say that you make 134%, let's say that your income doesn't meet the requirements for Medicaid, but you still don't have enough money to buy a private insurance because they're expensive, then you have an opportunity to go into what we call a state exchange. So every state by 2014 has to have an exchange program set up. And what that exchange program is going to do, it's kind of like, does anybody know what Orbitz is? Has anybody gone on Orbitz or Expedia or Priceline? Okay, a few people know what that is. So you go on the computer and let's say you want to take a trip. You get to compare all these airlines or whatever. Well, the state exchanges are going to work kind of like that. It's going to be web-based. You're going to go on and you're going to be able to compare all these different insurance plans. It's also going to provide those affordable options for people who kind of fall through the cracks. Again, it's for the people who, they don't make the requirements for Medicaid, the income requirements, but they really don't have enough money to get private insurance, and they struggle with maybe a job that doesn't provide insurance, which happens a lot as well. And this is also an opportunity for jobs to be able to provide affordable insurance for people as well. Now, there are some Indian-specific provisions, and remember all those tribal leaders I was talking to you about that were fighting for that Indian Healthcare Improvement Act? They were also working to get these things in this law. They were working really hard to get special provisions for Indians. And what we would like is for the Congress to fully fund the Indian health care system. I mean, that's really what we want. That hasn't happened yet, so they're working to try to find other ways to get health resources into tribal communities and urban Indian communities. So here's the Indian-specific provisions in the law. Under the state exchange, so let's say you go in there, you go into Orbitz or whatever your state exchange is, and you start comparing your insurance options, and let's say you get an insurance plan under the state exchange, then if you make less than 300% federal poverty level, you don't ever have to pay a copay if you're an Indian. Never have to pay a copay, no matter where you go. You don't have to pay a copay. The other thing is that no matter what your income, if you're in a state exchange, let's say you're making 301%, somewhere between 300 and 400%, the federal poverty level, then you don't ever have to pay a copay if you go to an I, a T, or a U, which this place counts. So if you go to an IHS, a tribe, or an urban Indian health program that's funded under Title V, not all urban Indian organizations are, just this one, and this is the only one in the state of Michigan. So if you get services here, you never have a copay. And then the other cool thing is that the federal HHS is going to pick up the cost for all those copays that you don't have to pay. And the reason that's a really good thing is because it helps you build a better relationship with your state. Because if the state had to pick it up, they might be really upset of the fact that they had to pay your copay because they don't have money, and so they would be struggling with it, and it would create tension between you and the state. So this was a good thing, and our tribal leaders are really thinking about that because they didn't want to get into a situation where they're fighting with their state. And I don't know how much you guys know about state-tribal relations, but man, it's sometimes a challenge when you're sharing borders, right? So they really thought about this, and they said, you know what, we can't let the states pick up the tab, because if they do, it's going to really create a lot of conflict for tribes and for Indian people. So the impact, of course, is, again, more Indians with insurance, so we need that.